it is relevant, how it is different from why it needs special attention, special care from various specialties. So in this session, we will be conducting a panel discussion. Why it is pertinent? Because as a geriatric patient comes in touch with the healthcare, they don't come with they do come with one problem, but their interventions or their the care they needs is multidisciplinary. So it is very important that we understand the nuances, the actual the experience they have in the hospital, and at what level various interventions can be done, and how one discipline intersects with the other in giving a holistic care. So with this, we move ahead in this panel discussion, as our panelist has been previously introduced. But I again welcome Professor Afzal Azim sir from Department of Critical Care Medicine. Rama Tripathi ma'am from Dietetics Department. She is Chief Nutritionist with us. And Dr. Kumar Keshav, who is Additional Professor in Department of Orthopedics at Apex Trauma Center. Dr. Saurav Shekhar, he's Assistant Professor in Department of Infectious Diseases. And our Public Relation Officer, Kusum Yadav ma'am. So to begin with, as 3 points have been highlighted in previous discussions, which have come out very prominently. One is the fall, the frailty, fall, which is a risk factor for elderly. So I'll start my discussion with opening statements from an orthopedics expert that as falls are common in geriatric because of n number of reasons, because of n number of risk factors. So our question to you from orthopedics point of view, how fractures are different in elderly from the fractures as we seen in younger population or adult population?
The thing is that in elderly population, the bones are weak because of multiple reasons. Either there is osteoporosis. As we all know that everybody has the highest bone mass at the age of around 25 to 30. After that, the bone mass only decreases. It never increases, whatever you do. So all that we can prevent, we can do is that, like, we can prevent decrease in the bone mineral density. So in the elderly population, the BMD is quite low. The patients are osteoporotic, and so they are very prone to, number one, falls. There are several studies which shows that if there is low vitamin D levels in a patient, the chance of fall in itself is more, not just the fractures. Even the chance of fall is more. So the fall is weak, number one. Number two, since the bones are weak because of osteoporosis mainly and other factors as well, so low energy trauma is seen in elderly population. हल्का सा वो गिर भी जाते हैं कई बार, उन्हें पता भी गिरते भी नहीं है लेकिन फ्रैक्चर हो जाता है. पेशेंट से पूछने का पता चलता है कि हाँ दर्द हल्का सा हो रहा था. When once we get the X-ray done, then we see that there is a fracture. So low energy fall होता है. And there are certain sites which are more prone to fracture in elderly population. जैसे hip fractures, we all know that they are more commonly seen in the elderly. Wrist fracture. My teacher used to tell me a story. Like a woman gets up at night, she catches her toe in the carpet, and she falls down. And actually there were two ladies which fall down. One lady saw a white cat and fell down, and she fractured her wrist. Because the white cat symbolizes that the prognosis is good of the wrist fracture, the body is fracture. And another lady sees a black cat and she falls and she sustains a hip fracture. Because the prognosis of the hip fractures are very poor compared to the wrist fracture. So these two fractures I would say are more common in the elderly. They are low energy falls. And again, if we want to operate these patients, we have to really do a lot of pre-anesthetic checkups and all those things before we can get. So things are a bit tricky in the elderly.
So you rightly pointed out that with elderly, there are certain vulnerabilities, there are certain risk factors, and once they get this fracture, so the complications are more compared to the because of other reasons, age and other nutrition and other factors. The risk complications are more, and one of common complication that once they get operated, they get admitted, and there is a risk of development of delirium, and sometimes there is underlying dementia which has not been taken care of. So patient do land up in getting into an ICU. So from this, I want to have some word with Professor Afzal Azim sir. That is age a criteria for getting admissions in ICU? Age, does age put a patient to get more at risk of getting, if get admitted in a hospital, so their ICU admissions are more. So how age and ICU admissions are related?
First of all, I would like to thank the trainers we have General Hospital for organizing such a putting area of medicine and bringing it as a scientific question today. Also, thank the hospital administration team for the assistance week today. Like before I answer this question, like let me have an audience vote. So there are so many people here. आपका क्या लाइक आप हाथ खड़ा करिएगा कि आपके घर में कोई बुजुर्ग है 70 साल का 80 इयर्स का 75 इयर्स के ग्रैंड पेरेंट्स ग्रैंडफादर सो इफ यू सफर फ्रॉम सम इलनेस वुड यू लाइक टू गेट एडमिटेड इन आईसीयू जस्ट रेज योर हैंड जस्ट रेज योर हैंड
Yes, please.
Just raise your hand. Those who say yes, I would like them to be admitted. And those who say no, so then the discussion is over. If there are no hands, the discussion is over. That means nobody wants them to get admitted times for no respect.
You have to give general opinion,
Yes,
but whatever you feel. Yes. Please participate.
Nobody wants their elderly to come to ICU. The discussion is over. And you see, you saw the presentation of Dr. Kausar. He showed the pyramid is changing. Pyramid change over. So it is not like it is changing from a pyramid, it is changing to a rectangle sort of. That means more and more geriatric patients. And because of the advancement in the medicine and technology, the advancement, so they will obviously be able to have a longer lifespan. So the more the longer lifespan that means, yes, there are chances that in ICU will get elderly patients. You know, like what is likely to happen actually in the coming years or decades, for India, I would say decades, because we are several decades behind the rest. We are going to have geriatric ICU. Definitely, we are going to have geriatric. And those ICUs will be managed by the medical team who are trained in geriatric medicine. That is absolutely correct. Because that is a totally different subset of patient population. So किसी ने बताया कि मुझे कि आना चाहते कि नहीं आना चाहते? No hands. Okay. Now I tell you something about my ICU data. हमारे ICU में क्या है? So when I got a call from Dr. Prema, so I just said, let me see what has happened in the last 2 years in the elderly population. How many patients more than 60 years? How many patients more than 80 years? And what has been their outcome? Just a very brief understanding to get an idea. And I also like congratulate Dr. Prema, like when she asked me to have some questions for the discussion. So I thought, and this is a very good area of like research and understanding like what is happening to our population. So what I found is last 1 year we had 22% of the total ICU admissions was the elderly population. So out of 400, we had 22%, which were 60 plus, 10, yeah, 80 plus. Now 80 plus, we had some patients who were 90 plus now. Let me admit it in. We had 8 patients in the last 6 months who were 90 plus. And you know what was the mortality? We lost 1 patient. 7 got discharged, 90 plus. Out of those patients, 22%, हमारे ICU में आए, more than 60 years, between 60 and 80 years, the mortality was 40. Now, if you compare the mortality कि कितना मोर्टेलिटी इन पेशेंट्स में है जो एल्डरली हैं और कितना मोर्टेलिटी उन पेशेंट्स में है जो लेस देन 60 इयर्स है कंपैरेबल our total ICU mortality is somewhere around 40 to 50%. So they are also falling in the same bracket. तो इसका मतलब क्या है? What is the conclusion? What do you understand? Huh? Old is gold. Yes. Old is gold. Age is just a number.
The elderly patient in the ICU, even if they don't have as serious condition as the young is having. So that data is little better.
See, but that is also correct because as Dr. Kaushal very like he explained in his talk that what happens is जैसी एज बढ़ रहा है हमारे physiological functions they are decaying and they as this is normal aging phenomenon. So they get less chance. So if you have some, if you detect some issue in your elderly population and you have the right admission at the right time, the right place, you may have a good outcome. The problem is when they move from one hospital to another, one OPD to another, and they are traveling for days, and then when they come to us, all their organ functions have already. That becomes a lead. I think so. Early detection of the complication and early treatment. Why not? And I would say कि ICU में age is just a number. The thing that matters is what is has been the quality of life before this acute illness. And if it is an acute illness, कोई acute infection है, कोई acute deterioration हुआ है किसी भी organ function में और वो ICU में आ जाए, he has a very good chance of recovery and all efforts should be made for that particular. And first 4-5 days are very important. So all aggressive management for preserving the organ functions is absolutely important. And then you can take a call, what is happening? So I think so like age is just a number. So we should not refuse ICU admissions just because we are getting a call for an elderly patient. Obviously, they have a number of issues, but yes, and give a full strength assessment and trial of all the aggressive management for such patients.
Thank you so much, sir, for these insightful reflections on the fact that age is just a number, and that ICU age should not be, should age be a criteria for the ICU admission or not. So moving ahead with the point that in ICU the risk of infections are already very much there, and of course elderly are at risk of getting infections. And in the hospital care, I want to move on to Dr. Saurav on the use of antibiotics, in elderly, and how it is this use is different in the geriatric population compared to the adult population.
Thank you, Dr. Domdi, and first of all, I would like to thank Prerna ma'am for giving me the opportunity. So antibiotics is something which is used rampantly in all the age group, be it pediatrics, adult and elderly. But in the elderly, as sir was telling, the physiology is different. The elderly population, the overall muscle mass is decreasing. They have more fat, and hence they usually even a patient of say 80-85 years with a normal creatinine also, it may look like his kidney function is normal, but if you calculate the creatinine clearance, it will be low. Which is with a lot of us. This population having multiple CAD, CLD. So these are some of the factors which we do not encounter in a young healthy. So while giving a drug, we need this phenomena that they will have a decreased renal clearance, they will have a decreased hepatic clearance, and hence we need to modify our antibiotics cautiously. Second thing is polypharmacy. I think sir, all the speakers in the previous talk told about polypharmacy, right? Polypharmacy, why it is even more important in the elderly is because of the drug interaction. In the young adult population, well, polypharmacy will not be much, but because the elderly have comorbidities, there will be a lot of drugs the patient could be on. And then again, putting the patient on a high-end antibiotic in the, say, in the ward of the ICU, there would be interaction, which again is something which, as healthcare workers, we do not consider, or it like bounces off our minds. So these are some of the important factors that we need to dose properly, but we also need to do what the Hippocratic oath we take, right? Prima non nocere, that first do no harm. So you need to take care of the side effects of the antibiotics and do look at the drug-drug interaction, which is much more, I believe, in the elderly population.
Thank you, Dr. Saurav. But with in continuation to this, I just want to ask one more point that you are highlighted about that we have to optimize with the use of antibiotics in the hospital as well as in the ICU. But another aspect to this is the prevention. So in one of the slides, Professor Usman has highlighted about the role of vaccination and such an underutilization of vaccines in the elderly population. So what are your thoughts on the usage of vaccination in elderly? And
This term of so everybody knows that children need to be vaccinated.
Yeah.
But there is nothing like there is no देना ही है vaccine बच्चों को.
we have national program.
Yeah, we have national programs and vaccines are made available free of cost in the government setup. But nobody talks, especially in the developing countries or in India, nobody talks about adult vaccination, especially the elderly vaccination. So first we need to understand why elderly need to be vaccinated, because they have a phenomena called immunosenescence. That is, their immunity is declining. So this both the infants and the elderly, they form the two spectrum of the population. So immunosenescence along with multiple comorbidities. So automatically they are much prone to go into a severity of a disease when they get home. Classical example would be influenza with the seasonal influenza. When there is a peak, you have much more morbidity or mortality or land up in the ICU as compared to someone who is a young adult. So this is why vaccination is important, because we want to improve the quality of the life of the elderly population. And one of the way of preventive medicine would be to vaccinate them, so that both in terms of financial constraints as well as in terms of increasing the longevity, we can improve the quality of life. Now, why it is neglected is because, like sir showed a very nice study. I calculated only 5 patients were vaccinated in the population, 0.7%. Out of 500, 600, 5 patients were vaccinated. So this is an extremely low number. And the reason is, sir touched upon it, is the lack of knowledge, or we often forget in the OPD. Here, one of the most common reason is लोगों को पता ही नहीं है. Sometimes when I explain, the patient attendance or aston is that yes, side effect. Singlets for herpes zoster, pneumococcal as sir was showing. अगर ये हम लोग देख पाए, it would benefit a lot in improving the morbidity, mortality, and improving the quality of life.
Dr. Romit, can I say something?
Yeah, sure.
I'm sorry to interrupt, but just after Dr. Saurav has talked, Sister Yogita and Sister Rindita please खड़े हो जाए. तो जनरल हॉस्पिटल पर हम लोग सभी एल्डरली पॉपुलेशन को, सारे एडल्ट्स को वैक्सीनेट करते हैं, और हमने सबके लिए लिटरेचर भी बनाया हर वैक्सीन के लिए, हिंदी में, अंग्रेजी में, और चेकलिस्ट बनाई है, यूट्यूब के वीडियो फॉरवर्ड करती है सिस्टर, सबको 1 हफ्ते का टाइम देते हैं, उसको पढ़ के आते हैं कि क्या क्या वैक्सीन को ले रहे हैं, उसके कॉन्ट्रा इंडिकेशन देन दिस दोस यू टेक प्रॉपर कंसेंट और हम वैक्सीनेट करते हैं. सो आवर वैक्सीनेशन रेट्स आर एक्चुअली वेरी वेल. सो vaccination people are both very knowledgeable in this, and I request all the staff who are present here, please, adult vaccination is a very important thing. सब उसमें पार्टिसिपेट करें. जो बच्चे हैं वो अपने बड़े लोगों को ला सकते हैं, और जो बड़े हैं वो खुद अपनी वैक्सीनेशन कराएं. So just extending what we said in the.
That's what, like only request would be कि आप मैडम के पास भेज दो, मेरे पास भेज दो, we'll advise the vaccine. You don't have to do anything. Just whenever an elderly more than 60, 65 years is coming to your OPD, ICU ward, keep it in the back of your mind. Attendant को भेज दो, patient नहीं आ पाएगा कि send to GH, send to infectious disease OPD, and we'll write the vaccines. There are 2 or 3 vaccines, you don't have to worry. बस आपको इतना दिमाग में रखना है कि medicine या infectious disease, or lot of people are also vaccinated. Our lot of departments, especially department are vaccinated, but मैं खुद भी कभी भूल जाता हूँ मेरे पेशेंट पे जो एडमिट होता है, that is true. So try to send them if you don't know, and then we tell the attendant कि जब पेशेंट ठीक हो जाए, discharge हो जाए, go to GH and you can take this vaccine.
Thank you, Dr. Saurav. So you mean that there is a need for to fill this gap, that is knowledge, attitude, and practice. We have to have the knowledge, we have to aware them, then it comes into an attitude, and then the practice will move forward. So this underutilization will improve further. So thank you so very much. Now another aspect for this prevention is, beside we have vaccination, we need to take care of the adequate nutrition among the elderly population. So on this aspect of nutrition, with respect to elderly nutrition, as sir has highlighted in previous talks, we have seen there are many myths related to the elderly nutrition. So from a nutritionist point of view, we want to understand how elderly nutrition, what are the elderly nutrition requirements, and how we deal with this.
थैंक यू रोहित जी। सबसे पहले मैं डॉक्टर प्रेरणा को थैंक यू बोलूंगी, उन्होंने फर्स्ट टाइम जेरियाट्रिक सेगमेंट को इतना ज्यादा हाईलाइट किया है। और कुछ भी बताने से पहले मैं ये भी आपको बताना चाहूंगी कि अब हमारा जेरियाट्रिक न्यूट्रिशन का ओपीडी डेज भी हम फिक्स करने वाले हैं आफ्टर दिस सेशन। तो जैसा कि कौसर सर ने बहुत ज्यादा हाईलाइट किया कि हाउ टू manage the dietary portion of the elderly people, तो उसमें सबसे पहले मैं 3-4 चीजों का जिक्र करना चाहूंगी। फर्स्ट ऑफ ऑल, जैसा सर ने कहा, मेडिकेशन उनके लिए बहुत ज्यादा इम्पोर्टेंट होता है, और वो एक पूरा जैसा सर ने कहा, कभी कभी हमें दूसरा पेज भी पलटना पड़ता है। तो उसमें ज्यादातर उनको जैसे कि एसिड रिफ्लेक्स या डायबिटिक्स मेडिकेशंस बहुत चलते हैं, जिसकी वजह से उनके मिनरल्स डिप्लीशंस जो बॉडी में होते हैं वो होते हैं। सेकंड वन इज सार्कोपेनिया, दैट इज एज ओल्ड रिलेटेड मसल लॉस होता है, वो बहुत ज्यादा इशू होते हैं। उनके कॉग्निटिव फंक्शंस की वजह से उनका टेस्ट स्मेल का इशू होता है। इसके बाद उनका डेंचर इशू होता है, तो कुछ च्यू करने में बहुत ज्यादा इश्यूज होते हैं। एंड इनमें से ये ट्रांजिट टाइम है, उसमें बहुत ज्यादा फर्क आता है, तो डाइजेशन इश्यूज बहुत ज्यादा होते हैं। इसके साथ उनकी फ्रेजिलिटी या बोन डेंसिटी में बहुत ज्यादा कमजोरी होती है, तो उसकी वजह से उनके फ्रैक्चर्स और ऑस्टियोपोरोसिस के इश्यूज बहुत ज्यादा होते हैं। तो दैट इज द मेजर इश्यूज। अभी क्या है कि जैसा कि सभी ने कहा, बच्चे और बुजुर्गों में ज्यादा फर्क नहीं होता है, बिकॉज दे आर वेरी रिजिड इन देयर एज, तो उनको ये समझाना बहुत मुश्किल होता है। तो अभी क्या है, जैसा कि सर ने कहा कि अगर उनकी एज के हिसाब से थोड़ा सा ज्यादा भी है तो कोई प्रॉब्लम नहीं है। कैलोरी एंड डेंस फूड पे हमें ज्यादा फोकस करना है। तो उसके लिए सबसे पहले तो मैं ये कहूंगी, अगर कहीं पॉसिबिलिटी है तो वो अपने आसपास के न्यूट्रिशनिस्ट या डाइटिशियन से संपर्क करें, और जो भी उनकी डाइट है उसमें प्रोटीन इज अ किंग, बिकॉज देयर इज अ सार्कोपेनिक सिचुएशंस, और उनकी जो मसल्स लॉस है तो उसमें थोड़ा सा रिपेयर करने के लिए प्रोटीन्स की जरूरत सबसे ज्यादा होती है। प्रोटीन के सोर्सेज आपको सबको पता है, डेयरी प्रोडक्ट्स, नॉन वेज में फिश, चिकन, एग्स और दालें और सोयाबीन। एंड समटाइम्स अगर आपके दांत अलाउ कर रहे हैं तो आप सीड मिक्सचर्स को भी, जो हमारे नट्स हैं वो ले सकते हैं। एंड द बेस्ट थिंग इज ट्राई टू फोकस ऑन लोकल अवेलेबल एंड सीजनल अवेलेबल थिंग्स, बिकॉज लेटर एज में थोड़ी फाइनेंशियल इश्यूज होते हैं, देयर इज नो डाउट, डेफिनेटली होते हैं। सेकंड वन इज बिकॉज ऑफ डाइजेस्टिव मोर्टेलिटी, तो फाइबर की बहुत ज्यादा सख्त जरूरत होती है। तो जो भी फाइब्रस फूड है
उनको लेने की कोशिश ज्यादा करें। और पर डे का जो रिकमेंडेशन है प्रोटीन वाइज, जनरली हमारा जो रिकमेंडेड डाइटरी अलाउंसेस दैट इज 0.8 ग्राम पर केजी पर डे। बट जो population में उनमें हम कोशिश करते हैं, if there is no medical issues, then 1.2 के लिए 25 to 30 ग्राम तो हमें रिक्वायरमेंट होता है, उसको देखना चाहिए। अब बात आती है फैट की। जनरली बहुत सारा मिथ है कि हमें चिकनाई नहीं लेनी है, बिल्कुल फ्री कर देते हैं। दैट इज नॉट गुड, बिकॉज ब्रेन के फंक्शंस के लिए हमें फैट की उतनी ही जरूरत होती है बाकी और बॉडी फंक्शंस के लिए जितनी और न्यूट्रिएंट्स की होती है। तो जो भी हमारे गुड क्वालिटी ऑफ फैट है, या ओमेगा 3 and 6 रिच फैट्स है, या नट्स है, या फिर जो भी हमारे ऑयल है, गुड क्वालिटी ऑफ ऑयल, उन्हें हम डेफिनेटली ले सकते हैं। इसके बाद बात आती है, सबसे जरूरी होता है विटामिन डी, कैल्शियम, विटामिन B12 एंड पोटेशियम। जनरली क्या होता है कि इस एज में सॉल्ट को, अगर नॉर्मल कोई भी मेडिकल इशू नहीं है, वो सॉल्ट को डेफिनेटली बिल्कुल कम कर देते हैं, उसकी जरूरत नहीं है। डेफिनेटली आपको बहुत ज्यादा नहीं लेना है, बट जो नॉर्मल रिक्वायरमेंट है उसको लेना है, एडेड सॉल्ट नहीं लेना है। अब बात आती है बिकॉज ऑफ मसल स्ट्रेंथ, पोटेशियम की हमें बहुत सख्त जरूरत होती है। एंड नंबर ऑफ सोर्सेज, कोकोनट वाटर, बनाना, आपकी जो ये शकरकंद जिसको हम स्वीट पोटैटो बोलते हैं, आपके नॉर्मल बॉइल्ड पोटैटोज, ये सारी चीजें हम ले सकते हैं। इसके बाद आइए, जो कैलोरी का जो सोर्सेज है, मेन जो स्टेपल फूड है हमारे इंडियंस का, दैट इज सीरियल। तो हम कॉम्प्लेक्स कार्ब यानी कि जो हमारे मल्टीग्रेन्स हैं उनको कंबाइन करके हम डेफिनेटली अपने कार्ब्स को नॉर्मल अमाउंट में ले सकते हैं। बहुत ज्यादा रोटियां कम करने की जरूरत नहीं है। इसके बाद आइए, जो आपका कैल्शियम के लिए ये तो हो गया फूड की। जैसे कि कौशल सर ने कहा, सप्लीमेंट्स की बहुत ज्यादा जरूरत होती है, बिकॉज जब आपका सपोज फॉर एग्जांपल B12, आपका स्टमक एसिड सिक्रेशन कम होगा, आपकी एब्जॉर्बेंसी नहीं होगी, यू नीड B12 सप्लीमेंट्स थ्रू एनी मोड, जो भी आपके डाइटिशियन या क्लिनिशियन एडवाइस करते हैं। देन विटामिन डी के लिए, बिकॉज स्किन की थिकनेस और स्किन की जो कहते कैपेसिटी दैट इज डिक्रीज, बहुत ज्यादा सनलाइट का या जो भी विटामिन डी है उसको एब्सॉर्ब नहीं करे। विटामिन डी, कैल्शियम, आयरन, इन सभी सप्लीमेंट्स की हमारी नॉर्मल रूटीन डाइट के साथ बहुत ज्यादा जरूरत होती है।
Thank you so much, ma'am. For this, I must say that our audience have got some very enriched nuances of this geriatric nutrition, and they must be applying this in their routine as a caregiver of their geriatric population at their homes. So again, now moving forward on the last segment, that among all this, the caregiver education, the communication is a very important, that plays a very important role when an elderly population, because mostly they comes with the some caregiver, either their children or some relative. So adequate communication, they are adequately directed in one from one segment of the hospital to another. The lies between different departments is adequate. So for their a very pertinent role of public relation officers comes in. So I want to ask Kusum ma'am, who is our public relation officer, what is the role as how would you see the role of as PRO in geriatric care?
For organizing symposium. Actually, public relation is very commonly misinterpreted as marketing skills or putting larger than life picture. But in a hospital setup, when we deal with elderly people, it starts and ends with one word only: empathy, empathy, and empathy. You have to treat your elderly person with compassion, give them. And much have been said on this topic by Dr. Shaleen and then Dr. Tanmay. But it is very sad to hear that our last section of the society still feel elderly people as burden, and then that leads into social isolation, then depression, anxiety. You have to just build their trust, win their trust, and for that, communication skills play a very important role. You have to be very tender, very open communication. You have to be very clear in communicating with them, but not, the communication should not honest, but not brutal. it should be very kind and compassionate. Secondly, communication barriers are there because when we deal with elderly people, they may be suffering from dementia, Alzheimer. You explain the entire thing, the next day they forget everything, then they don't recognize you also. You have to be very patient with dealing with them. And thirdly, this is a Herculean task, but it is not impossible by constant communication. And you can just learn the communication skills. We try to organize this kind of workshops with our PR personnel. They can learn, and this is it. I think I can just come up with this.
Thank-
Dr. Robin. This is just a question for Madam Hussain, like, has it ever happened like, because you keep on getting calls for transfer, क्योंकि 80-90 साल का कोई आया हो और आपने सोचा इसको मना ही कर देते हो अपने लेवल पे सीएसएम नहीं भेजते.
We never refuse at our end. We always request you to please see and decide whether it is feasible to shift that
Okay, so
patient.
this has never happened.
No.
That's great.
We do not. Do
No,
not
I
allow
cannot
it.
absolutely मना नहीं करता.
I know. I know this.
That's very encouraging. Thank you, ma'am, for these insights. And so it is rightly highlighted that empathy and compassion at every level of care is the core for geriatric care, and from there all other things stands out. So with this, I want to conclude this panel discussion as we have some paucity of time. So I really want to thank our esteemed panelists for being part of this discussion, and our audience for patient listening and their. I think you must have some questions, so we'll be taking them on a cup of tea with our experts. So thank you so very much, our panelists, our esteemed speakers from the previous sessions for being part of this discussion and part of this very pertinent topic on geriatric care. Thank you so much.
Thank you, sir, for the insightful session. I request Dr. Rachna ma'am, Rachna Srivastav ma'am, Dr. Rachna Agrawal ma'am, and Dr. Punita ma'am to please give the token of appreciation to our respected moderator and panelist, Dr. Romil Seni, sir. Ma'am, ma'am. Dr. Afzal Azim, sir. Dr. Kumar Keshav, sir. Dr. Saurav Shekhar Paul, sir. Ms. Rama Tripathi ji, Ms. Kusum Yadav ji.
जब तक वो हो रहा है तो मोट करवा दो.
I would like to express my gratitude towards Dr. Prerna Kapoor ma'am, as I am the junior resident that is working under her, and I am so lucky that I got this chance, as she always ensures that we should treat every elderly patient with so generosity, and she had also make a protocol for vaccination of adult vaccination. So thank you, ma'am, for a great mentorship, and I'm so lucky to work with you.
चलो, तो हमारे अरविंद जी हैं एक जो है MLT, और ये बहुत ही अवेयर पर्सन है. अरविंद जी है कहाँ? हाँ, तो इन्होंने अभी बैठे बैठे ओथ लिखी है जो सबको लेनी है प्लीज, और एटलीस्ट इसको कुछ कुछ याद रखना है जो आज हमने इतना आयोजन प्रयोजन किया.
So I request you all to kindly join me in reciting it. मैं प्रत्येक वृद्ध मरीज के साथ
सर आप लोग बैठे, आप बच्चों खड़े हो.
मैं प्रत्येक वृद्ध मरीज के साथ धैर्य, संवेदनशीलता और गरिमा के साथ व्यवहार करूंगी। मैं केवल रोग का उपचार नहीं, बल्कि शारीरिक, मानसिक और सामाजिक स्वास्थ्य का भी ध्यान रखूंगी। पारिवारिक एवं सामाजिक भागीदारी। मैं परिवार जनों को जागरूक कर सहयोगात्मक और सम्मानजनक देखभाल का बढ़ावा दूंगी। मैं डिप्रेशन, डिमेंशिया और सामाजिक अलगाव के संकेतों को पहचान कर उचित परामर्श दूंगी। मैं वृद्ध जनों में ब्लड प्रेशर, शुगर, हार्ट डिजीजेस, खून डिसऑर्डर्स आदि के समय समय पर स्क्रीनिंग सुनिश्चित करूंगी। थैंक यू।
वेरी बिग हैंड फॉर ऑल ऑफ यू टू बी और इसे याद भी रखना है और अरविंद जी के लिए बहुत बड़ी तारीफ हो जाए तो इतने जागरूक है तो हमें यहाँ बैठे बैठे ये लिख सकते। थैंक यू।
Now, and another thing was said about that all the had become key.
That is because in Amma was so.
नेशनल एंथम के लिए बोल दीजिए नेशनल एंथम।
नहीं पहले बोल से
Now, I invite Dr. Akshita and Dr. J to come to the dais for and propose vote of thanks.
Respected chief guests, distinguished guests, esteemed faculty members, and dear colleagues, on behalf of the organizing team, we express our sincere gratitude to all who contributed to the success of Aging with Dignity, Navigating Geriatric Care, held today at SGPGIMS under the aegis of the Geriatric Society of India.
सबको रोक लीजिए। गाने से कुछ आएगा नहीं के लिए।
May I request everyone to please wait for the national anthem.
एक मिनट सर, एक मिनट।
Before we adjourn for high tea, I would like to request the honor of your presence in standing for the national anthem. Thank you.
Thank you, Jiyas. Thank you. I have no words to express my thanks to all of you. Thank you. हमारे chairs